My name is Claire Yang. I'm one of the urologists here at the University of Washington. I'm going to be presenting urological chronic pelvic pain syndrome, a holistic perspective. I've done some research in this area over the years and been involved with other people doing research in the United States on this area, and I'd like to share some of my insights as well as some of the new findings that people have been developing over the last few years. It's really an honor to be here with your group today, and I appreciate this opportunity. So on the slide, I'm in Seattle, up here in the upper northwest corner of the United States, and I was just looking this up last night. Washington State, the region that I'm in now, is just a little bit smaller than Ghana. Seattle is a very beautiful city. I'm hoping if anybody comes to Seattle one day, you will come and look me up at the University of Washington, and I will be happy to take you around. Seattle is surrounded by large bodies of water as well as mountains. And if you walk around the University of Washington campus, you can see Mount Rainier, which is shown right here, which is always covered in snow. Our department, the Department of Urology at the University of Washington, has taken this image and put it onto our department logo. Speaking of our department, we have a pretty big department. We have maybe 25 urologists. I believe one of my colleagues, or maybe even more, has spoken to your hospital group in the past few months. And we also have a very new faculty colleague who joined our department, who's originally from Ghana, and I believe his father taught the medical school associated with your hospital, the Komfo Anokye Teaching Hospital. So today's session, we'll do some introductions. I'll do my presentation, which will last about an hour, and then we can have some questions and discussion. I forgot how long we planned to make this session. Dr. Adai, what is your understanding, or what can your group, what is your group scheduled to do? Hello?
We had planned for about an hour, but I think it'll probably be fine if it goes a bit over.
Okay. And is there a way that they can, or Dr. Adai or somebody in the group can just give a little introduction of who they are so I know who they are?
Yeah, Dr. Adai, do you want to give a quick introduction? Or any other volunteers?
If that's not possible, that's fine too. Okay, well, I'll just go ahead and start. So today we're going to talk about urologic pelvic pain conditions, and in women who complain of pain in their bladder or urethra, but not the gynecologic organs. We call that interstitial cystitis or painful bladder syndrome. In men, however, if they have pain in their bladder or urethra or any other pelvic or perineal organs, we call that chronic prostatitis or male chronic pelvic pain syndrome. This is how many urologists feel about chronic pelvic pain. It's an old picture of a person being tortured by all sorts of sharp objects. And why is it that urologists are so unhappy with chronic pelvic pain and managing chronic pelvic pain? Well, it's because that many of the treatments are unsuccessful. And unsuccessful treatments lead to unsatisfied patients. Um, Many of the treatment options that we've been taught to offer are non-surgical. And since we're surgeons, we like to do surgery, and there are no surgical treatments that we really offer. And then lastly, and what I'm hoping to address today is that for the most part, we urologists don't understand chronic pelvic pain or urologic pain. We don't know what's going on down there. So this all creates a lot of mystery and is intimidating. But there is hope, and hopefully I'll present some of the information that will make this less mysterious and intimidating. Our objectives today is to describe these pain syndromes, interstitial cystitis, painful bladder syndrome, chronic prostatitis, chronic pelvic pain syndrome. We'll discuss some of their similarities and then the findings of the MAP Research Network, which is a very large, long-standing research effort here in North America to look at chronic pelvic pain syndromes. And then we'll finally talk about a paradigm approaching treatment. To start off with, let's talk about interstitial cystitis. This is a picture here of a fire arising from the bladder, because that's what a lot of people describe their sensations as. So the American Urological Association defined ICPBS as an unpleasant sensation, and that could be pain or pressure or discomfort perceived to be related to the urinary bladder, associated with lower urinary tract symptoms. And all these symptoms have to be longer than 6 weeks duration. And here's the important part: in the absence of infection or other identifiable causes. And given the name of this condition, interstitial cystitis, and painful bladder syndrome, you are made to think that the problem with this person describing these painful sensations is in the bladder. So this is a clinical syndrome of pelvic and bladder pain, along with urinary symptoms such as urgency, frequency, and there can be other urinary symptoms as well. These symptoms, especially the pain, gets worse when the bladder fills, and this pain is felt in a number of places. Like I mentioned earlier, urethra, bladder, in women, the vagina, the perineum, the suprapubic area, the low back area. The symptoms get episodically worse, meaning they can come and go, and there is no urinary tract infection or other infection or inflammation, cancer or stones to explain the symptoms. There have been a number of reports to try and estimate how common this is, and it's believed that the incidence or prevalence of this pain syndrome is much higher than reported because it's difficult to diagnose the condition. One estimate is 500 people in 100,000. The median age at diagnosis is in the mid-40s, and there is a 9-to-1 female to male ratio. At least that's how it was classically described. The people who come in with these symptoms often have other conditions causing pain, such as gynecologic diseases, irritable bowel syndrome, fibromyalgia, migraines. The people who come in with these symptoms are more likely to report childhood bladder problems. And many of these patients have seen multiple doctors before they're diagnosed. On physical exam, again, pain is what people experience, but tenderness is pain elicited with the examination. And so there is in women, suprapubic tenderness, pelvic floor spasms, anterior wall tenderness, anterior vaginal wall tenderness. In men, there are actually a large number of men diagnosed with chronic prostatitis, and we'll talk about that later, who actually have symptoms very consistent with interstitial cystitis, and they have suprapubic tenderness, pelvic floor spasm, tender rectal examination, and pain radiating to the testicles and penis. On people who present with these symptoms, they'll get a number of tests, urinalysis, and on the urinalysis, it's usually clear, but some people might have some hematuria or pyuria, but that's not very common. The urine culture is invariably negative. If you get a voiding log or a voiding diary, people will report small frequent voids, because if they wait too long, it's too painful. So they don't let their bladders stretch out too much because it's too painful as the bladder fills. On cystoscopy, classically it's described as having petechiae or Hunner's ulcers, but in reality, these findings are uncommon, and they are definitely not pathognomonic of IC or painful bladder syndrome. In fact, there's nothing pathognomonic for IC or painful bladder syndrome. If you do a cystometrogram on these people, they might have an overactive bladder, they might have a small capacity bladder, but again, that's not pathognomonic of IC. And then the cytology, or if you're looking for cancer, that's going to be negative. So in short, IC PBS is a diagnosis of exclusion. So after you've ruled out all the other possible causes of pain and urinary symptoms, then only then can you come to this diagnosis of IC PBS. But one question we have to ask is that if it's really a diagnosis of exclusion, is it really a disease of the bladder? And we'll come back to this question. Now let's consider chronic prostatitis or chronic pelvic pain syndrome. The matador shown here probably has chronic or has pelvic pain, but he actually has acute rather than chronic pain. So the classic concept of chronic prostatitis is that there is a mysterious infection which invades the prostate, and the prostate is shown here with the seminal vesicles, and then as a result of this infection, it causes pain. And this idea has been around for a long time. In fact, one of the founders of the American Urological Association, Ramon Gutierrez, wrote in the journal Urology in 1912, chronic prostatitis is a very subacute, long-standing inflammation of the gland. And he said, in all cases, the etiological factor doubtlessly consists in bacterial infection. And so this idea has been carried on for decades, as long as urology has been around, that pain in this general area in men is due to prostate infection. But we'll find that it's not necessarily the case. In the late 1990s, the United States National Institutes of Health decided that this area of prostatitis needed research, and they realized that a lot of different people were calling different conditions prostatitis. So they came up with a different kind of subgrouping of prostatitis. So type 1 is acute bacterial prostatitis, and that's the kind that we see where men come in with high fever and and a very tender prostate exam, and maybe imaging will show that they have a prostate abscess. Type 2 is chronic bacterial prostatitis. Type 3 is chronic non-bacterial prostatitis, which they called at the time prostatodynia or chronic pelvic pain syndrome. And type 4 is asymptomatic inflammatory prostatitis, meaning that the ejaculate or seminal fluid had white blood cells, but the men didn't have any symptoms. The definition of chronic prostatitis or chronic pelvic pain syndrome, therefore, falls into this category of type 3, which is prostatitis, which is long-standing pelvic pain, urinary symptoms, and long-standing, meaning not just a couple weeks, but many, many weeks or many months of pelvic pain and urinary symptoms unrelated to ongoing or identifiable infection or inflammation. The estimated lifetime prevalence of this in men is about 5 to 9%. And in 2004, this diagnosis was attributed to 2 million physician visits per year. Men who are diagnosed with chronic prostatitis come in with a whole range of symptoms. And starting at the far left, the black bar is penile pain. And next is perineal pain, urinary frequency, double voiding, ejaculatory problems. The pink bar is urinary urgency, suprapubic pain. The gray bar is rectal pain, hesitancy, testicular pain, dysuria, and back pain. So there's a whole bunch of symptoms associated with these urinary tract pains and urinary symptoms. On examination, these men report pain when their lower abdomen or suprapubic area is pressed on, if the groin, penis, and scrotum and rectum are examined. And then, of course, a urinalysis is obtained. And then classically, or traditionally, what's described to work up prostatitis is to get expressed prostatic secretions, or EPS. And that's where the urologist does a rectal exam, as shown in the picture here, and massages the prostate for about a minute. And what that does is forces out some of the seminal fluid out of the prostate into the urethra, and then that fluid drips out and is looked at under a microscope slide for and examined for white blood cells. And that's what people would call inflammation of the prostate. But as we'll talk about a little further on, EPS findings are mostly meaningless in this concept of chronic pelvic pain or chronic prostatitis. Other tests that men with these symptoms might get is cystoscopy. Some show petechiae and Hunter's ulcers, but mostly the cystoscopies are unremarkable. And if urodynamics are performed on these men, again, it shows perhaps overactive bladder or small capacity bladder or a normal bladder. So just like IC, CP, chronic prostatitis, chronic pelvic pain syndrome, is a diagnosis of exclusion. And just like with IC, if CP, CPPS is a diagnosis of exclusion, is it really a disease of the prostate? So given these two questions, let's get away from the conventional wisdom, and which is that these are problems of the bladder and the prostate. And if we rethink this condition or these conditions, what if these syndromes are not a problem of the end organ? And what if we consider IC and CP as pain syndromes and not consider end organ pathology as the source of pain? And maybe even think that, is there even a single point of pain in these people. And if we're going to rethink this, what is the evidence for changing the classic way of thinking? So on this slide are a list of treatments for IC on the left and CP on the right. All of these treatments listed here have demonstrated some efficacy for the syndrome that they're listed under in small trials, single hospital trials, or single group trials. But in large randomized studies, none of these have been proven to be consistently effective. And what I'm going to do is focus not on, or just a couple of these in chronic prostatitis to prove the point. So this idea of an infection causing chronic pelvic pain, or inflammation causing chronic pelvic pain. In 2003, Curtis Nickel showed that inflammation, meaning finding white blood cells in prostatic fluid, was just as common in chronic prostatitis patients as in asymptomatic men. So control men were enrolled for this study, gave fluid, ejaculate fluid, and there was white blood cells in asymptomatic men just as frequently as was found in chronic prostatitis men. The second bullet point, prostate bacteria is just as common in symptomatic men as asymptomatic men. And this was a study done at the University of Washington in which men with chronic prostatitis had prostate biopsies done, transperineal prostate biopsies, so they weren't contaminated by fecal flora through the rectum, and asymptomatic men, healthy men with no symptoms, were also given a prostate biopsy. And these biopsies were cultured and bacteria grew from the two groups in equal numbers. And finally, Dr. Schaefer did a study at Northwestern University showing that inflammation and infection in prostatic fluid does not correlate with the severity of symptoms in men with chronic prostatitis. Another study here comparing tamsulosin with an antibiotic, ciprofloxacin, in a large group of almost 200 men with chronic prostatitis. And there were 4 groups in this study: placebo, cipro alone, tamsulosin alone, or cipro plus tamsulosin. And at the end of 12 weeks, the symptom scores were nearly the same in all 4 groups, showing, one, that there is a significant placebo effect, but also showing that antibiotics or alpha blockers by themselves do not have any more benefit than placebo alone. Another big study of alfuzacin, an alpha blocker in chronic prostatitis, CPPS, showed that there was no difference in improvement between the placebo group and the alfuzacin alpha blocker group. Again, showing that there is a very strong placebo effect, and single pharmacologic treatment does not show any benefit to placebo. Now, let's talk about IC and CP and consider the possibility that they are variations of the same condition. And this is another picture of somebody being tortured, of a sharp object aimed in somebody's perineum, and that person being suspended and even weighted down on this torture device. So the common characteristics of both these conditions are that of pain in the urinary tract, bladder, your urethra. It extends into the genital organs. Both groups have suprapubic pain and pelvic pain. They both have urinary frequency and urgency, and both groups report high degrees of sexual dysfunction. Also, both groups seem to have a percentage of people, men and women, both with these symptoms, also have other comorbid conditions, comorbid pain conditions, in fact, such as fibromyalgia, headaches, irritable bowel, and other chronic pain conditions. And then in a small study at the University of Washington, a group of men with chronic prostatitis on cystoscopy were found to have petechia in response to hydrodistension, a common treatment for interstitial cystitis. And we found that 60% of men with prostate pain at some point demonstrated petechiae, which we thought were isolated to interstitial cystitis, but apparently it's common in both men and women. As a result of these commonalities, again, the National Institutes of Health then started a research effort and put together a large research network called MAP, MAPP, which stands for Multidisciplinary Approach to the Study of Chronic Pelvic Pain. It started in 2009, and this research group is still going on in multiple sites across the United States and Canada. And in phase 1, they enrolled 424 subjects with interstitial cystitis or chronic prostatitis. They also enrolled 415 pain-free control people to compare to, and also 200 positive controls. That is 200 other people with chronic pain syndromes other than IC or CP, to compare the different kinds of groups. They collected a huge amount of questionnaire data, biosamples such as saliva swabs, rectal swabs, urine, and blood samples, and then also did all sorts of imaging on them. And the effort of the research network was focused not on the bladder or the prostate, but looking at associations of IC or CP with other pain syndromes, looking at biomarker development, looking at brain imaging studies, looking at behavioral and psychological aspects, and then systemic manifestations. They considered IC and CP to be about this, to be variations of the same condition rather than different conditions. One of the findings was that there are two kinds of phenotypes, if you will, of people with chronic pelvic pain. About 25% of the 424 people reported pain just in their abdomen and pelvis, but 75%, the majority of this large group, reported pain at other sites beyond the pelvis. So in other parts of the body. The findings were similar in men and women. And it was found that patients with widespread pain that extended beyond the pelvis, had more severe chronic pelvic pain symptoms than those with pelvic pain only. And what this suggests is that there's a presence of a centralized pain phenotype, a subgroup characterized by central nervous system alterations or systemic pathologies. They also found that 38% of these participants had other pain conditions, as I mentioned earlier, like fibromyalgia, irritable bowel, chronic fatigue syndrome, and that there was a poor correlation of pain and urinary symptoms. So people would report urinary symptoms like urinary urgency and frequency, and they would report pain, but those symptoms the pain didn't necessarily track with the urinary symptoms. They also found on brain imaging central nervous system changes on MRI and functional MRI. They found lots of psychosocial problems, quality of life, and stress levels were different in people with pain. And there was a low likelihood of improvement associated with certain psychological variables. So there are a lot of other factors that seem to be playing into chronic pelvic pain syndrome other than just a bladder problem or a prostate problem. So with all this evidence, perhaps we should be rethinking pain, and specifically urological pain. The classic way of thinking about pain was described by a French philosopher, René Descartes, back in the 1600s. And he describes a pain impulse travels from the site of the injury to the brain. And there's a single pathway. And when the pain or when the fire hits the skin, then the pain is registered in the brain. However, there was a an anesthesiologist named John Bonica, who was at the University of Washington. He was an anesthesiologist, and he was one of the founders of pain medicine, a subspecialty of medicine just focused on the treatment of pain. He was also a professional wrestler, and working his way through medical school, he paid for it by wrestling, and it was thought that he had a lot of injuries during that time and had chronic pain. And so that's what motivated him to go into pain medicine. And he said the peripheralist model assumes that pain results from tissue damage and from continued afferent nociceptive input, meaning that there's something irritating or causing the pain at a certain part of the body. But there's another way to think about it. And he said the centralist model rejects the need for any continued impulse from the periphery. It posits a central generator mechanism responsible for keeping the pain alive. And what he means by central, something in the nervous system, either in the spinal cord or the brain, that keeps sending pain signals, even though there may not be tissue damage or irritation going on at the periphery. We also have to think about acute versus chronic pain. And this idea of the peripheral pain generation explains acute pain. And acute pelvic pain, that means recent onset. For acute or new pain, we think about it as a symptom of underlying tissue injury and disease. But in chronic pain and chronic pelvic pain, the pain itself becomes a disease. There's no tissue damage, there's no ongoing inflammation or infection. The pain itself becomes the disease. And so one of my colleagues said chronic pain is as different from acute pain as cancer is from a wart. And so we have to sort of separate our idea about pain as a result of having surgery, of getting hurt in an accident, and separate that from chronic pain, which is ongoing and not and unchanging because there are different physiologies. And you can think about pain and this description in a holistic way. There's nociception, or the triggering of receptors which send the signal of pain, and pain is an experience. And then if somebody experiences pain, there is suffering, which is another layer of the pain experience. And then as a result of the pain and suffering, then people respond to that pain and suffering with pain behavior, which may or may not make things better. So there's a holistic concept of pain. It's not just one thing causing this symptom. It's many layers of things causing the distress. We also have to get away from the idea of pain, and especially chronic pain, being started by one particular thing. Pelvic pain can be a result of gynecologic, urologic, gastrointestinal, musculoskeletal, and neurologic factors. And more importantly, it can be any combination of things. So chronic pelvic pain isn't just maybe due to one thing, it's likely due to a number of different things. Back to Dr. Bonica's idea of this central generator of pain, of chronic pain, there is this neurologic factor of the brain and the spinal cord. And one of the theories of chronic pain is that as a result of the chronic barrage of signals, noxious stimuli of pain, the central nervous system appears to change its circuitry. And so the hypothesis is that the brain and spine circuits rearrange, and the result is that there is an altered sensory experience, meaning people are experiencing pain when there's no trigger, no visible trigger, and the same stimulus does not feel the same to different people as a result of this rearrangement. One of the pieces of evidence for that is in one study where different points were pressed on in people with chronic pelvic pain. And even though there might be one spot, say right here, which is the most painful spot, there are other spots all over the pelvis which are painful. So it's and this is not true in people without pain. So if you have, or without chronic pain, so you have widespread pain and tenderness, even though nothing is going on at any of those spots. We did a study testing heat sensation in men with chronic prostatitis. And we found that men with chronic prostatitis reported higher pain intensity at lower temperatures than controls, men without pain, with perineal heat testing. When we tested another part of the body in both the patients and controls, there was no difference. And so our hypothesis was that more C fibers, or the kinds of nerve fibers that send pain signals, are being activated in chronic pelvic pain syndrome, or there's more activation of pain circuits, which is called central sensitization. And how we tested this was in men, there was this thermode, which is connected to a machine which generates heat. This is a scrotum, here's a thigh, and here's a thigh. And we put this heat thermode on this area underneath the scrotum and tested men's sensation to pain. This is a diagram which shows what changes, how the circuits rearrange. So in people who have healthy nervous systems, don't have chronic pain, pain fibers process pain, and other fibers process other sensory modalities. However, in pain, patients with pain, normal fibers transmit pain sensations, and sensitized pain fibers actually pick up pain sensation from a wider area. It's hard to explain. I'm just showing you that this picture mostly to demonstrate the fact that we believe that the pain circuits in chronic pain get changed in the central nervous system. So how can we translate that into treatment strategies and options? So what do we know in 2021 about chronic pelvic pain? We know that urologic chronic pelvic pain syndromes, both IC and CP, they are chronic pain syndromes, not just a problem of the bladder or the prostate. There's evidence against infectious etiologies. Monopharmacotherapy is minimally effective. It does help some people some of the time, but not widely. And there's evidence for systemic and pelvis-wide manifestations, and early experimental evidence shows that the central nervous system is a major component of pain perpetuation. So if we were to take a more holistic approach to treatment, we have to think about more than this, the prostate and the bladder and infection. We have to address possible causes to pain, including neurological factors. And we have to also address factors that influence a person's perception of pain. Back to this diagram of pain, pain behavior, suffering, pain, and nociception. We have to take all of this into account when addressing the patient with chronic pain. So how to approach it? Well, no antibiotics and no narcotics. Not that narcotics don't help, but if we give narcotics, then chronically all we do is create somebody who becomes narcotic dependent. A better strategy is a multimodal therapy approach, which incorporates more than one of these factors listed below. And there are other treatment options. We just don't have a good guide on how to say what to treat people with. But I'll talk briefly about what I do. I start off by talking to people, educating them about pain, and then telling them how they can do self-care, meaning how to avoid things that make their pain worse, teach them about posture or seating and ask them what makes things better, makes things worse. Are there things in their diet that make their bladder pain worse, such as coffee or alcohol, and then avoid those. What are the things that help make things better? Have people change their behaviors to mitigate the pain that they're having. I also start people on non-narcotic pain medications, such as low-dose tricyclic antidepressants, because those have been shown to help with chronic pain. Also, the gabapentinoid medications, such as gabapentin and pregabalin, or not pregabalin, Lyrica, and those medications, because those will be helpful to try to not cure the pain, but make it more tolerable. If people have severe bladder symptoms, such as overactivity, we'll treat the overactive bladder symptoms. Or if they have obstructive voiding symptoms, we'll treat that with the alpha blockers or the anticholinergics. I'm not saying treat these people with those medications alone. I'm saying in combination with these other treatments, I believe that the combination multimodal therapy approach is more likely to get better results. Pelvic floor physical therapy is very popular in the United States now for the treatment of chronic pelvic pain, and I'll describe that in a moment. Chronic pain psychosomatic treatment, yoga, mindfulness-based stress reduction, or just physical activity in general. There have been many studies in other chronic pelvic or chronic pain conditions, such as fibromyalgia, that show that physical activity, regular physical activity, which is a big problem for Americans, perhaps not so much in West Africa, where people just sit in the United States, people are sitting around and not doing anything all the time, but physical activity is very helpful for the treatment of chronic pain. And then if possible, enrolling the help of a pain psychologist to help people understand and get a grasp of their pain. The American Urological Association has some treatment guidelines for interstitial cystitis, not specifically chronic prostatitis, but the clinical principles of management, which are outlined in red, identifies some of the same principles that I was just talking about: multiple simultaneous treatments, um, pain management, um, and in general, treatments should be ordered from most to least conservative. So you don't want to hurt people uh, trying to treat their pain. Now, here's a study which demonstrates some efficacy of the gabapentinoids for chronic pelvic pain syndrome. There was pain improvement in the pregabalin group compared to the placebo group. So this is one of the first studies to demonstrate this in urologic chronic pelvic pain. And pelvic floor physical therapy. About 20 years ago, this started becoming not popular at that point, but the idea of pelvic floor physical therapy to treat pelvic pain started being recognized. And Dr. Weiss wrote that pelvic floor physical therapy arrests the neurogenic trigger leading to bladder changes, decreases central nervous system sensitivity, and alleviates pain due to dysfunctional muscles. And why is there muscle dysfunction in chronic pelvic pain? Well, this was an early study done by a physiotherapist, which showed that in men with chronic prostatitis, they had internal pelvic floor muscle pain at a much higher rate than men without pain. They had internal muscle spasm at a higher rate compared to controls. They had external muscle tenderness and external muscle spasm in much higher rates than men without pelvic pain. And so it seems like pelvic floor muscle problems are very common. And in fact, I would say extremely common in people with chronic pelvic pain. And one way to explain that is using the example of people with a pinched nerve in their back. If they have back pain, then their back muscles start to spasm as a result of the pinched nerve. Same thing, if there's pain in the pelvis, then the muscles in that area spasm and are tender and hurt in response to that other pain. There was a study done in 2009, which our university was part of, comparing pelvic floor physical therapy in people, men and women with urologic chronic pelvic pain, compared to global massage. So we enrolled 200 people with pelvic pain conditions and randomized them to pelvic floor physical therapy or global massage, because somebody was thinking, well, is it just the touch? Is it just the massage aspect of pelvic floor myofascial release that's giving people improvement? Or is it just any kind of touch would do the same thing? And this study showed that even with global massage, meaning massage, people getting massage all over their body rather than just the massage of the pelvic floor massage was myofascial release was much more efficacious than just global massage alone. And why is that? Why is the pelvic floor spasming? Well, you can see that if you have pain in the urethra or the bladder area, the overlying pelvic floor muscles can respond very, because of their proximity and all the nerves which are arising from the spinal cord in the same level, can respond with spasm very easily. And in many men with chronic prostatitis, they describe ejaculatory pain. And why is that? Well, because the bulbospongiosis muscles are spasming and they're right there. Or they describe penile pain. Well, these bulbospongiosis and ischiospongiosis muscles are right there. And so it makes a lot of sense that the pelvic floor and the surrounding muscles are spasming, and pelvic floor physical therapy can help with that spasm and discomfort. So PT might help primary muscle pathology and dysfunction, secondary muscle pathology and dysfunction, but what it won't fix is primary non-skeletal muscle pain generators. So in summary, we've gone over the two common urologic pelvic pain conditions. We discussed their similarities, some of the research network findings, which looked at these two conditions in this as a variation of the same condition. And then I presented a paradigm for approaching treatment holistically. I will not say that I have the answer to treating these patients. All these patients are very different. Each patient needs something different, and we still don't understand very much about pain in general to be able to cure people. What I talk to my patients is that when we do treatment and therapy, our goal is not to cure them of their pain, but just to decrease the level of pain, decrease the level of discomfort so that they can be more functional. I do not promise cure of their pain. So here are the references. If you need to go back to it, and I'm happy to take any questions or participate in a discussion. And I'll stop sharing my screen.
Thank you so much, Dr. Yang.
Yes, that was a very wonderful presentation, Dr. Yang.
Thank you.
Really, it's an eye-opener. It's been an eye-opener for some of us because most of us, for me, I've always looked at this chronic pelvic pain syndrome as infection.
Mm-hmm.
Sometimes changing antibiotics, sometimes adding some painkillers here and there. And the person comes back and tells you, doctor, I didn't get any improvement. And it's so frustrating.
Yes.
And telling us today that even in America, you tend to have the same problem.
Yes.
And that we should be looking at multimodal. So my question is, do you ever employ the services of a psychotherapist or a psychologist in some of these management of some of these patients?
Yes. For the people who have really long-standing pain that can't work anymore, that they just stay at home, they feel like they can't do anything, I definitely encourage them to seek the help of a pain psychologist. For people who are having pain who don't have so much dysfunction, they're still able to work, they're still able to do things. For those people, I don't send them to the pain psychologist because their pain hasn't crippled them. It hasn't made them dysfunctional. But yes, certainly for the severe pain patients, I do.
Okay. And so for the choice of analgesia, beyond the MAO inhibitors, like is NSAIDs advisable on the looking at the chronicity of the disease? NSAIDs, I mean,
Yeah.
Are they advisable?
So all medications, for long-term use aren't necessarily a good idea. So what I tell people is that if you find NSAIDs helpful, say they have testicular pain, if you find them helpful, take it when you need it. If you want to take it long term, I put a limit on how much they can take, and for how long they take it, because as you know, that NSAIDs taken in high doses for a long time, it will cause kidney damage and many other complications. So again, I try to, if they find it helpful, I try to say use it in short periods of time.
Okay, that's fine.
Mhm.
Kati, is it possible to unmute the others? Some of them may have questions to ask. Or on the other hand, the participants can raise their hands and ask any question they want to ask. But really, I'm very excited about this topic because of the regularity with which I tend to see patients coming with chronic pelvic pain. And
Yes.
mostly you do a urine culture, there's nothing in there. You are forced to give an antibiotic. They come back after 2 weeks, 3 weeks, and it's the same. And you have to keep repeating the same drug. Of
Yeah.
course, sometimes I have also had the occasion of giving this antidepressant, tricyclic antidepressant, like imipramine,
Mhm.
but they tend to stick with you. Unfortunately, I didn't have this background where you need to tell them that we are going to manage this pain and not really to treat it. And
Yes.
so sometimes after a few visits to you, they lose confidence in you and they leave, only to come back after a long time, of shopping for treatment. And it's quite a debilitating condition, actually.
Yes. I agree. It's the same, I think, all over the world. People come to you, they want a fix. And when you try to say to them, we're going to help you manage the pain, not make it go away necessarily, they don't like that and they go to another doctor. Yeah. We have the same issue.
Hmm.
And I think it just requires patience on their part and your part to slowly help them come to realize we don't know enough about what's causing their pain to have them be cured. So the best we can do is help them manage it.
Okay, so how routinely do you do cystoscopy, urethroscopy in cases of pelvic chronic pelvic pain syndrome?
I rarely do cystoscopy if the urinalysis is clear. And most of the people I see, maybe because they're all tertiary patients at this point, most of the patients I see have clear urine, so I do not do a cystoscopy on them because more than likely somebody else has done cystoscopy on them already, and so I don't do it again. Yeah.
Okay.
There's a Dr. Kigongo who's raised their hand.
Yes, thank you very much, Doctor. I have a question. Thank you for the topic because true, this is a common condition even in Uganda. And then now you've opened something different. I'm going to have a different view tomorrow if I'm seeing my patients. I'm more concerned about the study, MAPP study. I wanted to know, they did a functional MRI. Did it add any more information between those with pain and the control group?
So there are changes, both structural changes and functional changes on MRI. So functional MRI looks at the circuits, the different parts of the brain that are activated with a certain task. And so in both people, in people with pain, their brain structure is different slightly. Some areas have a little more white matter than gray matter compared to the controls. And using the functional MRI, the circuits processing sensations are different between the two groups. That's all we have. We can't make any extrapolation as far as a clinical impact, but what it does tell us is that these people with chronic pelvic pain are different. They're feeling sensations differently than people without pain. And so it just goes to, it reinforces the idea that we have to look at different ways of treating these people and not just as a prostate problem or a bladder problem. But it's very, very early in this research before we can make any clinical conclusions.
Thank you. My other last question, probably, we talked about cystoscopy. For you, you said most of the patients are tertiary. I worry when I see patients with chronic pain and maybe the irritative lower urinary symptoms. Mm-hmm. I don't want to miss a carcinoma in situ or something. So I don't know, when you see irritative symptoms and cystoscopy has not been done, I assume you would also do, because for me, I routinely do, but again, like you said, they are usually normal.
Yeah. If somebody had hematuria, even microhematuria, I would definitely do cystoscopy. And those are the people with carcinoma in situ. They would have microhematuria, that would show up on cystoscopy or on cytology. So yeah, in a patient without a diagnosis, definitely, but if everything has been ruled out, then I wouldn't do it again.
Okay, thank you. Those are my questions.
Does anybody else have any questions or want to present a case?
Yeah. So a few instances I've done cystoscopy and you see these yellowish patches all through the uterus like that. And what all through the uterus?
Dr. Amete, I did not hear your question because the audio was not projecting. Maybe you can type it into the chat.
I think that might have been Dr. Adai. But,
oh, sorry.
Oh, you're fine.
Yeah. I was saying that I've done a few scopes for patients presenting with chronic pelvic pain. And mostly what I find are yellowish patches that tend to span the entire urethra. And I was asking your experience
Dr. Adai, I wonder if you can type your question into the chat. Your sound keeps cutting out.
in your body. Look that are seen along the urethra.
Sorry, Dr. Adai, we can't quite hear you. Maybe we can answer Dr. Amita's question and you can type your question into the chat.
All right. I think we're having broadband issues.
Did you see that in the chat, Dr. Amita? Okay. Great. And do we have any other questions? Okay, well, thank you so much, Dr. Yang, and thank you to everyone else for coming and asking such great questions.
Yes, again, it's been my honor to be part of this group today. Oh, one last question. Can you talk us through the myofascial release? Yes, so what the pelvic floor physical therapists are trained to do, just like the physical therapists for back problems or leg problems, they are experts in the muscles of the pelvic floor, and they describe release of the muscles that are tight and spasmed by massaging and pressing on them. And you can reach the muscles of the pelvic floor externally in the region of the perineum or in the region of the obturator ring or on the in the region of the buttocks. But also a key component to pelvic floor physical therapy is internal pelvic floor muscle release, which in men is through the rectum. And on either side of the prostate, you can palpate different pelvic floor muscles and pressing on those muscles to help release the spasm. And you can do that in men, and in the women, transvaginally, the pelvic floor muscles are palpated and massaged. And then what the pelvic floor physical therapists also do is help people recognize those muscles. We all can identify our leg muscles and our arm muscles and our hand muscles, and we have pretty good control of them, but not everybody recognizes what their pelvic floor muscles are. And so that's another treatment that the pelvic floor physical therapists do. If we feel like our arm is our leg muscle is spasmed, we know how to massage our leg muscle or do maneuvers to release that spasm, but we don't necessarily know how to recognize our pelvic floor muscles. Not that they teach people how to do internal pelvic floor massage, but they tell people how to sort of gain control and identify those pelvic floor muscles that are giving them pain and spasm. Does that answer your question? Another question, does supravesical urine diversion make a difference for unbearable IC? In some cases, yes. So those are the cases where the bladder has lost its compliance. It has shrunken down and become a fibrous, non-compliant reservoir. And for those people, it will help. I have seen people undergo cystectomy, young people who have had chronic IC, young women, and nothing was actually wrong with their bladder. They were still compliant bladders, and they still had pelvic pain afterwards. So again, it's a function of us not knowing in a given person what's causing their pain. So definitely supravesical diversion is a last resort, and that should be done only very rarely. All right.
Okay, or is that all the questions?
Okay. Well, thank you all for your attention. I hope this has been informative for you. Again, it's been my honor to present to you all and share this time with you.
Very, very much so. It has been very informative and we are very grateful. Thank you very much.
Okay, I hope to run into some or all of you again sometime in the future. Bye-bye.
Definitely. Bye-bye. Thank you, Kati.
Yeah, thank you.
Great. And bye-bye, Dr. Kigongo.
Yes, bye-bye, Dr. Dai. Nice to meet again.
Yeah.
Bye.
Bye. Thanks, everyone.
I'll visit you in Uganda one day, okay? Bye-bye.
You're welcome. Yeah.
Bye, guys.